Hello everyone and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams and I'll be administering today's webinar. Today we have Dee LeBeau-Hein speaking on referral, service coordination, and documentation. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you're preparing for an exam that you seek additional preparatory help and let this course be one of the many tools you use to prepare. Our next webinar in this series is scheduled for May 20, when Ed Haycroft will present Counseling Families, Partners, and Significant Others. We also offer the American Indian and Alaska Native Behavioral Health Series, and we'll welcome Dr. Beth Boyd from the Disaster Mental Health Institute at the University of South Dakota on May 6 to discuss community-based psychological first aid. For more information on our webinar series, you can contact me at the email address or phone number provided on the slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH request form is available for download in the Files pod in the webinar screen, and will also be sent in a follow-up email. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. If you've never used the Adobe Connect system before, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Dee LeBeau-Hein. Dee is a member of the Minikuju Band of the Cheyenne River Sioux Tribe in Eagle Butte, South Dakota. She currently works as a mentor for the Tioshbaye in engineering program at the South Dakota School of Mines and Technology, and serves as the president of the board of directors for the Sacred Heart Center, where she oversees a women's shelter and adolescent program. Dee, thank you so much for joining us, and I will pass things over to you at this time.
Thank you, Kate. I appreciate it. I'm glad to be with you all again today. A lot of what we're going to go through might seem a little repetitive. It does build off of each other. So it's important to, I guess if you're going to take notes or whatnot, that'll be helpful. Because we do have some vital resources that you'll want to probably go visit afterwards. So the goals and objectives we're going to look at today with the referral process, service coordinating services and documenting contacts, community case management, and the strengths perspective, and then some of the research. The module was designed by Tom Kirk, and if you Google his name, you'll find this whole system that he developed. And what it's talking about is using the community resources to help with the recovery process for the individual. And this is what he's designed, the recovery-oriented systems of care. And this is a comprehensive menu of services and supports that are available in the community. You know, early on in treatment development and treatment planning, you know, we typically just work immediately with the client and the referring services, the referring service, like maybe if it was Department of Social Services or the court system, And that we just kind of kept it between those two, but now we're finding that as we broaden that support structure, it's helping with the recovery process for that individual. So here's a good example of that. Some of the services and supports that are available, a lot of our clients come in with issues with housing, perhaps with court systems, perhaps with the Veterans VA department. Some of them are coming in with employment issues and things like that. So a lot of these resources are interconnected and will work together to help improve the recovery process for that client. So as you're looking at this diagram, you can see a lot of the various programs or entities that you may be referring your client to, or your case manager, if you have one on staff, would be working with to help enhance that recovery process for your client. Ultimately, we're looking at of course, abstinence for the client, but you're also looking for ways that will help them socially connect with others, to get into housing that is safe and drug-free, to alleviate crime activity, and those kinds of things. So this is really a nice diagram to work off of when you're doing any type of referral. And referrals is basically utilizing all available support systems within the community to help that individual. And a referral is typically, when you clinically staff your client, your staffing team will work together and talk about what's best, services are best for that client. Some of the relationships that are just established and developed are with the community civic groups. Your spiritual community might be a vital factor if that person is traditionally spiritually involved in their tribal community. Having a referral system there, tribal leaders, and other professionals available. So this is a good starting to have something established, and maintaining that relationship with those individuals that you'll be using to refer. You're going to want to continually assess and evaluate those sources. One of the things that I have found is often calling agencies or those services and making sure that the same people are who our contact people are, because sometimes people move around within the agency. So it's important to maintain that relationship with them and keep up on who's working where and who's leaving, who's new, and keeping yourself visible in their resource agenda. So keeping that feedback resources regarding their service delivery, interpreting and using evaluation and patient feedback data. That's because you want to make sure that whoever you're referring your client to, they're getting the services that you sent them there for. Sometimes clients are very shy when it comes to meeting new people and new service environments, and will walk in sometimes, and if that person isn't there that they ask for, they may not ever return there. So it's important to keep that connection going and helping that client receive the care that they were referred for. Differentiating between situations in which it is important for the client to self-refer or for the counselor to refer. So when you're interpreting the assessment and treatment planning materials, if a client maybe is having marital problems, and if that's something that they're agreed to go to couples counseling or something, that's a referral that you can make. If they want to go see somebody and talk about a diet program that might help you, that's their self-referral. They're going to do something like that on their own. But it's something that you're going to work together on. Assess the patient's readiness for those referrals. Some patients and clients aren't ready to take on those referrals and may be ready later on in the treatment process. So it's important to gauge where they're at in the treatment process, if they're actually ready or not. So not wanting to force any type of change until the client is actually ready, and they understand what the referral process is for. So explaining that in a manner that's clear for them. Arranging referrals to other professionals and agencies or other appropriate resources, and again explaining that clear in language that they understand. And it helps to ensure that they'll get the follow through and they understand what you're doing certain things for. It's for their well-being and their recovery success. Exchange relevant information with the agencies or professional. I've had situations where we've had clients referred over to an agency, and then we've called to check on them, and they're not getting the services that we sent them there for. They're getting something else done. So there was a miscommunication. So it is important that when you're exchanging information, that it is clear what you're sending that client over for, that they're going to get exactly what you sent them there for. And in evaluating the outcome of that referral, because you want to make sure that the client's getting the correct care that they deserve, and the agency that you're referring to is providing that service adequately. And you'll see that by, again, interaction and ongoing contact with your client and with the agency. When we're looking at coordinating services, Native people have done that. In this picture, it's a winter count. And in this illustration, it's talking about the harmony that surrounds us, and how our people a long time ago, and being from the Great Plains, our people a long time ago lived off the land and worked and traveled with the seasons. So we were able to pay attention to what was needed within our immediate surroundings, and that's kind of what this picture is talking about. So in a sense, when we're looking at service coordination, that's kind of what we're doing. We're looking at what's available in our immediate surroundings, in our communities. So administrative, clinical, and evaluative activities that bring the patient and the treatment services together to work together. And it focuses on the issues and needs of that identified in the individual treatment plan. And I want to say, treatment plans shouldn't be one size fits all. It is very much individualized. Some agencies tend to think that if one client responds really well to something, then we should move more clients in that direction. That sometimes isn't always the case. So it's really important to individualize those treatment plans and understand your client, so you know what services you're able to provide. Service coordination includes case management and patient advocacy. Now, these two are not one and the same. Case management, you're going to find an individual in your agency that will basically work on managing whatever referrals you have for the community. So if you have a client that may be pregnant and will be leaving the facility, you're going to want to make sure that client's set up with prenatal health care. Or if they're diabetic, you want to make sure that they're set up with diabetes of their appointments. And a case manager will go out there and make sure get the time and the place and any prevention programs and things like that, and make that available for the agency to make those referrals and manage those kinds of appointments to help with the client. Patient advocacy is going out speaking on behalf of the client to help them get certain services. And it may be something like housing, or it may be joining a certain support group or something like that. But so they work a little bit different. It's kind of the same, but a little bit more so different. And they're going to establish a framework of action for the client to achieve specified goals that you would probably develop within the treatment plan. And the discharge summary and aftercare plan, those are all probably going to work together in coordinating services. And here's a link that you might want to go out to if you get a chance. And it gives a lot of good information out there on different types of things that are going on in recovery, and resources and things. Service coordination also involves collaborating with the client and their significant other their family. In Lakota, we say an extended family. We use the term as tioshpae, and sometimes that would include cousins, aunts, uncles, um, in-laws, those types of relatives that might be a strong support person for the individual rather than their immediate family. So it's important to collaborate with those individuals when you're coordinating different types of services. I worked at a residential treatment program, and one of the things that we did was when the clients came in and they would do a visitation, when they were allowed to have visitors, we did a visitation list. I had each client explain to me what their relationship was with the individual and how they were supportive to their recovery efforts. So we tried to build that support structure and system before they left treatment. And this was kind of some of the things that we did, in terms of providing, those kinds of services for them. So that person that they were going to would be helpful when they left and take them to meetings or, get them to their appointments or help them whatever way they could. Coordination of treatment and referral services, liaison activities with community resources. So there's, you might have a wellness center available. The client may want to do some, start working out and things like that. So you have somebody you can contact within that service. Liaison activities with managed care systems and ongoing evaluation of treatment progress. You all are probably working with different levels of care for each patient that you're working with. They might be in a chronic stage, or they might be in the higher level stage, and then you're going to back them down into the lower level of care. And keeping track of their treatment progress is key, and we'll look at some of the documentation that is involved with that. And ongoing evaluation of the patient needs. As a person comes into recovery and they start taking better care of themselves and taking better care of their immediate situation, their needs will change, and you'll be moving with that accordingly. Service coordination also includes initiating collaboration with referral sources, obtain, review, and interpret all relevant screening, assessment, and initial treatment planning information. Some of your screening tools you use when you immediately do intake with the client, but some of those screening tools are used through the duration of the treatment process to gauge how the client is doing in the treatment process. So it's important to be able to understand what screening tools you're using and how to interpret those and use those to the best benefit for the client and your agency to provide adequate service. Confirm the patient's eligibility for admission and continued readiness for treatment and change. And I think that's pretty basic as if you're a trainee and you're working with a clinical supervisor, they're working with you on how to identify a client's position in treatment in terms of where they're at in readiness for change. Complete administrative procedures for admission to treatment. Implementing the treatment plan establishes accurate treatment and recovery expectations with the patient involved significant others. As you identify those key people that are working with the patient or client in the treatment setting, you're working together to help identify what are attainable, what is something that they can work on together. Coordinate all treatment activities with services provided. Now on the left you see crisis, you see recovery, chance. So there's different areas that you'd be working with in implementing the treatment plan. You want to develop and maintain a community referral list, and this is where I mentioned earlier with the spiritual community. Working on the reservation, we had a number of clients come through that were traditionally involved in different areas when they were not actively using. They would participate in traditional activities, ceremonial activities and things. So as they got caught up in their addiction and moved away from that, when they're in recovery, that's one thing that they often want to go back to. So we'll talk to them about who they've worked with or who they're comfortable with, and then you have those clients that come in that have heard about it and have always wanted to be a part of that, but never felt quite comfortable approaching anybody or didn't think there was anybody in their family that knew about that. And by developing a referral list in the community, in a small community especially, you'll find that there's a lot of relatives that don't know that they're relatives that can help in this area. So it's really important to develop that community referral list and maintain that ongoing, as people move in and out of the area. Develop multidisciplinary collaborations within the community, accessible as needed. Deliver case presentations, use appropriate technology. So all these are going to be implemented in the treatment plan. As you're moving through, you're going to be working with the appropriate technology to take this information. Some programs are becoming more electronic, and they're not using hard copies anymore. So those are just some things that you might want to be mindful of. Some are using virtual counseling, where they're logging on to a program like a avatar site, and then they're going into counseling sessions that way. So technology is really changing. So I don't know what your agency is using or what you have access to, but those are some areas that you really need to be mindful of, and what's available for that individual in developing that treatment plan. Demonstrate accurate, clear, and concise verbal and written communication. The treatment plan is developed with you and the client, and sometimes as clinicians we tend to use language or verbiage that they don't understand, and they may not say anything about, and then just go through with it, and then later say, well, I didn't know what that meant. So it's really important that you're clear, and that you reiterate that they understand what you're describing or what you're explaining, and so they know what they're signing. And that'll be helpful for them in building that trust with you. Participate in interdisciplinary team building. That might be, you might be working with somebody in mental health, you might be working with somebody in wellness, you might be working with somebody in maybe the parole police department, or the clerk court system. You might be working with somebody right there in your agency with the substance abuse counselor. So there might be a interdisciplinary team building that you might be working with. So you may be participating in something like that, and you're all working together on behalf of that client. And participate in negotiation and advocacy, conflict resolution, problem solving, and mediation. So a client might ask you to be a part of maybe a court proceeding, or might help or ask you to be a part of a landlord negotiation and a lease agreement or something like that. So you may be called on doing things like that. So you're going to be assisting the patient in developing and maintaining contact, whether it's face-to-face, telephone, or electronically. Keeping contact with that individual is imperative, because of course they need that level of accountability, but you want to see that whatever treatment goals and objectives that you've established for them is working. So if you need to make any kind of adjustment to the treatment plan, you're able to do so in a fairly quick enough time to help with the treatment process. And again, you got documentation, and you want to document everything. Nothing. If you question whether this needs to be documented, you probably need to document it. But again, your clinical supervisors will discuss all that with you in your training. Service coordination also includes consulting. Summarize patient's personal and cultural background, treatment plan, recovery process, progress, and problems inhibiting progress. So you're going to need to understand that terminology and the procedures and roles of other disciplines related to the treatment of substance use disorders. We're seeing, you're probably working with a lot of co-occurring disorders. You might have somebody with a bipolar as primary and substance abuse as secondary. diagnosis. So understanding how those work together with the medications involved that might be prescribed for them while they're stabilizing their bipolar um, or symptoms, or you're going to want to understand what that all means. And a lot of times with mental health patients, they know their diagnosis very well, and they're pretty understanding of helping you learn if you don't, for the most part. But consulting with psychiatrists, psychologists in understanding what they're doing and why they're doing what they're doing um, is a big part of service coordination. Um, Cultural background is a big part too, because you want to understand a client's cultural upbringing and their background, and what maybe customs or language or beliefs that are going to be helpful in the treatment process. So if you're working with a specific ethnic group, it's really important to understand culturally, if they're immersed in that, what they're bringing to the understanding of their treatment process, which will help in the treatment planning as well as the recovery process. Consulting also contributes as a part of a multidisciplinary treatment team. Again, you're going to see that. And apply confidentiality regulations appropriately. As you're doing your referrals, you would identify basic information to the referral source. So if you're working with somebody and working in a very sensitive subject, you're not going to want to elaborate too much on that details of that subject, but be able to explain it in a general manner which they understand the referrals coming in, and that alleviates that uneasiness for the client. So it's up to them if they want to share more in depth, like they have with you if you've built that rapport with them. So confidentiality regulations, it's important that you understand where that applies and how that applies for each referral source, and what services you're coordinating with, how much information you want to give them, or are you allowed to give them. So maintain ongoing contact with the patient and involve significant others. Understand and recognize stages of change and other signs of treatment progress. You might have, as you're staffing your client, and I don't know how often you do that. We did it every day for the duration of the treatment process. But sometimes if we had emergencies come up or things like that, we were able to see different changes in the stages, or if they were regressing or if they were progressing. So we were able to adjust accordingly services that they needed. So it's important to recognize those stages and make the appropriate changes to their treatment plan, like I said, as you identify those issues are progressive issues. Plan to ensure progress toward treatment goals. And sometimes as you're providing or identifying those treatment goals, they may be addressed immediately while they come into treatment, but haven't fulfilled the goal. So you'll carry that on into their aftercare process. So understanding what those goals are, and what progress has been made to that goal, and what may need to be continued. So it's important to understand that as well, and describe and document the treatment process, progress, and outcome. So continuing assessment and treatment planning, you use accepted treatment outcome measures, because as you're identifying goals and objectives, it's got to be something that's measurable, that you're able to go back and look at, and the client can see that it's something that they can see the progress that they've made and that they're making, and that encourages them and inspires them to keep moving forward, that they're doing something right. We would have clients that would come in and relapse maybe after they leave treatment. They're back in the system within maybe 6 weeks, and they're coming in feeling bad about that, and we talk about progress, not perfection. The last time we might point out to them, the last time you came to treatment, you relapsed in 2 weeks. This time you lasted 6 weeks. That's progress, and that's something that they need to be mindful of, that something changed, something helped them last a little longer. So it's important to point those kinds of things out to your client as well. So they see something that's measurable. Continuing care, relapse prevention, and discharge planning with the patient and the significant other, that's ongoing. You're going to be looking at documentation, service coordination activities. So if you as a clinician aren't available and that client comes in a crisis situation, to be able to pull their file and see what they've worked on in a manner that you can pick up, from that point. I've worked with counselors that have been very vague in their contact with clients, where they would just had an individual session with client, and that's it. So it was really difficult to get an understanding what they worked on. Grief, we did worked on grief, stages of grief, or we identified different relapse triggers and things like that. So they're a little bit more specific. So you're going to want to put that in your documentation, but not give full detail. If somebody shares a sexual assault with you, and gets very in depth with you, you want to share that we discussed a sexual assault incident, something like that. But that's enough for the client, the counselor, or your coworker to pick it up and carry on if you're not there. So apply placement, continued stay, and discharge criteria for each modality on the continuum of care. And as you're progressing through your understanding of the treatment process, you understand the different care that are being provided for that client. And here on the right, you have relapse, pre-contemplation, contemplation, preparation, action, and then you have maintenance. So those all work together, and this is a diagram that's used out there by a number of treatment programs. So it would be important to familiarize yourself with these different changes, stages. So looking at documentation, it's important to understand that everything you document can be a source for legal documentation. And you'll understand more of that as you learn in your treatment planning and things like that, as you go through your courses or classes, however that works. But documentation is really important to be mindful of what you're writing down, what needs to be written down, what the client and you agree to be written down, so they understand why you're putting things in their chart, and why you're referring them to certain people, and what you're going to say when you refer them to certain people. That's all part of the documentation process. So writing things I know the ASAM book has some good illustrations on how to write some of those items in your treatment plan, or in your discharge summary, or in your aftercare plan, or when you're doing a referral. So if you have a book like that to refer to, sometimes that's helpful to get you started in documenting and writing those things. So documentation, you're recording the screening and intake process, and you might have a standard form for that, or you might have it on your computer, and you might have a program that automatically takes all that information in and generates some type of a report or a form. The actual assessment that you're using, there's a variety of assessments out there that are being used. The last one I used, I know the information that we put in was generated a narrative type assessment at the end of the intake. So it really depends on what you're using with your agency. And then you're recording the treatment plan and clinical reports, any type of clinical reports, any type of clinical progress notes. discharge summaries, and those any other patient-related data that might contribute, like their health, if they're doing physicals prior to coming in and they've identified as diabetic. You're going to want to identify those kinds of things in your paperwork. Demonstrate the knowledge of accepted principles of patient record management. Your agency will probably have that already established, so it's important to understand what your agency is using and why they use what they use. So it's composed in a timely, clear, and concise records that comply with regulations. And not only with your agency, but it may be state, federal, or tribal regulations. So document information in an objective manner rather than a subjective manner. So that's important to understand those differences. Protect patient rights to privacy and confidentiality. There's a lot of federal law now that requires certain documentation to be signed by the individual. And as agencies, we have to abide by certain privacy and confidentiality regulations. I know the new one out there you all probably are familiar with is HIPAA. We have to abide by confidentiality and privacy and how we handle those records federally. And then, of course, you have your state and agency regulations regarding client confidentiality. And one of the things, if you're in a small community, client confidentiality, sometimes, of course, they sign a document that states that we abide by their privacy and confidentiality. But if you're out in the community and they show up at the store and you're at the store, and they approach you and everybody knows that you work for the treatment program, that you need to let the client know that you may or may not approach them in a community event or activity out of respect for them, but also for their own privacy. If they want to approach you, that's up to them. That's their choice, but they understand that the privacy and confidentiality of that interaction. And then request, prepare, and complete release of information when appropriate. You're going to have a release of information form for anybody that you're going to refer the client to, and then it's going to be specific about what information you're releasing. It can't be, I'm sending the whole file over to the parole officer, that you're not going to do that. You're going to say, I'll release treatment progress notes, to a degree or something like that, but you got to be very specific about what you're going to release to that referral source and or any services that you're coordinating with. So it's important to discuss that with your client and make sure that you have adequate releases of information, and what you're going to release is clear. So they understand that, and they're comfortable with that. You're going to want to prepare an accurate and concise screening, intake, and assessment report. And in that, you're going to have psychoactive substance use and abuse history, clients that have been through different treatment programs. You're going to want to make sure you get release of information to maybe discuss with their previous counselor how they did at that treatment program, and maybe take a look at some of the treatment progress that they made at that treatment program, or regress that happened at that program. But understanding their history, physical health. A lot of clients come in to treatment not taking very good care of their health. So most programs require a physical prior to entering a treatment program. And if that's the case, then you're going to have accurate records and documentation of that, of their physical health. Psychological information, if they've done any psychological evaluations in the past. What was that about? Was that referral? Was that what was going on there? Unfortunately, we're dealing with a lot of suicidal ideation and unfortunately completions. And this is an area that I think we're going to see a lot more implemented into our intake process. Social information, anything that they've been involved in the community, perhaps, or how they've been socially interacting. There's a history of criminality, so their legal background, legalities, what's been going on there, gender identity. We've had clients that come in that identify opposite of what they're coming in as, so it's important to identify that. Cultural orientation, as I mentioned earlier, you're going to want to have a clear understanding of culturally where they're coming from, so you can provide adequate resources for them in their recovery. And anything else they may discuss with you, you're going to want to be able to document that information as well. Record treatment and continuing care plans that are consistent with agency standards and comply with applicable administrative rules. Again, your agency probably already has all this in place, so it's important that you understand your agency regulations and the rules thereof. Informed consent, document in a timely, clear, and concise manner. I know sometimes as clinicians we get really busy, and we want to remember to write something down, but the phone rings and we get distracted. Somebody comes to our office, we get distracted, and next thing you know, we totally forgot about writing something down. And then we go back when we have a minute and we try to recall that incident, and sometimes it doesn't come back clearly. So I've often told my clients when I have a pen and paper near a tablet by me, as they're talking, I'll be writing things down, just certain notes that help me remember to make to do something or to document something for them, and I'll explain that to them right up front, because sometimes they'll even ask, "What are you writing?" And I'll explain to them, well, so I don't forget, to do this, or so I don't forget to document that, or whatever. And it's done in a timely manner. So it's important to, I guess, be mindful of that. Recognize the importance of recording treatment and continuing care plans. I know that sounds redundant, but again, that doesn't always get done in a timely fashion. There's deadlines. I know working with the state, we had deadlines to have a lot of our continuum care progress notes in. So I know you all work under deadlines, and so that's why that's there to understand that. Record progress of patients in relation to the treatment goals and objectives. Again, you're going to want to make sure those treatment goals and objectives are measurable and attainable, and you're able to record that progress for the patient. If you've set something in there that in their treatment plan that isn't attainable, or the client hasn't agreed on, it doesn't help the client in their progression of the treatment, because it makes it look like they're not doing what they're supposed to be doing, when in reality that goal was never attainable anyway. So as you're developing that, it's important that you agree that this is something that they can do, and that you can do, and that you have adequate resources within your agency to do, or you have adequate referral sources out there to meet those goals and help them meet those objectives. So recording that progress is important. To use appropriate clinical terminology, review and update records, prepare clear and legible documents, and document changes in the treatment plan as needed. You want to prepare an accurate and concise discharge summary, because a lot of the agencies usually have to report to somebody when the client's leaving the treatment program, maybe the court system, or a housing facility, or wherever they're going back into, there's going to want to be a clear discharge summary. And that's going to consist of a patient profile and demographics, what the client came in presenting with, what their symptoms were, what the diagnosis was as a result of those presenting symptoms and the assessment, what interventions were used in addressing the diagnosis and addressing those symptoms, and throughout the treatment process. Critical incidences that may have happened within the treatment experience, progress towards those treatment goals, and what were the outcome, and then the aftercare plan, and the prognosis, and any type of recommendations that may be by the agency. Those are going to be imperative to be in the discharge summary. You're gonna typically see a lot of this information. The document treatment outcome using accepted methods and instruments. And again, your agency probably already has that established, but if you're not sure, take it to your clinical supervisor or your clinical staff and ask the questions. If you don't understand it, gather the information and take a look at it so you understand what you're doing and why you're doing what you're doing, and you know how to read it, and you can interpret that to the client. So it's gather and record outcome data, incorporate outcome measures during the treatment process, recognize that treatment and evaluation should occur simultaneously. They do work together. They have to work together. Appreciate the importance of using data to improve clinical practices. So a lot of your agencies may be working with grant monies, and if that's the case, they're going to want you to do an extra form, document extra information, and that's going to help you see what services that you may be able to enhance on or improve on, or what's working, what's not working. So there's some reasons behind why you have to do the extra form or whatever, but that you understand the importance of that. And then we're looking at case management and strengths perspective, and this is basically looking at a client's strengths, building off of their strengths. Every client that comes in has something to build off of, and this is looking at what that may be. Strengths perspective seeks to encourage patients to become more deeply involved in their own treatment. So rather than you doing the work, the client's doing the work, and they're identifying what it is that they can do, and when they see that they're able to fulfill some of those goals by a measurable instrument, they're more encouraged to do more, and then they're become more confident, self-confident that they're doing something that's really helping better their well-being. Simultaneously assist patients in learning how to acquire and retain resources that will support their recovery. When I had the clients that I had mentioned earlier identify relationships that they had with the individuals that they wanted to come visit them, some of them realized, as we were talking about, their friend Judy, that, well, you know what, come to think of it, all Judy and I ever did was use together. And I guess I never really realized that until you asked me. And my friend Susie, she she's in recovery, and ever since she's been in recovery and I'm using, we're not hanging out as much, but I can see that she would be a good support person because she's always wanted me to go to meetings with her. So it's something like that, that you're working, the client is able to see that the resources available for them that will help support their recovery, and they see that maybe they're not going to do well at an AA meeting, but they would rather go to a NA meeting, and they see the difference in that, and they're able to identify that, and again, that empowers them, and that gives them ownership of what they're doing, and it builds their self-confidence. So this is what strength perspective does. Some of the 5 principles case manager will be working with or looking at is facilitate the patient's identification of their strengths and their abilities and assets. And sometimes clients have a hard time identifying those. If you ask them, what are your strengths? Well, I don't know. Well, what are you able to do? Well, I don't know. I don't know. And so here's where your collateral contacts may come in handy. And a collateral contact would be like a family member that knows this individual very well and can tell when they're headed for relapse, or can tell when they're doing, when they're working with the or things like that. You would ask the client to talk to that person, talk to Aunt Susie, and see, what would she say your strengths are? What would she say your abilities and assets are? Because then, as they see that on the outside, then they're able to start realizing that, hey, I guess I really am a hard worker, and I didn't realize that, when I do have a job, I do really well at it. And others can see that. I didn't know that, so those kinds of things that help a patient identify what their strengths are. If they don't know immediately, you can kind of help them with that, identifying those things. Assist the patient in focusing goals, identifying alternatives, and locating resources by encouraging the client to identify his or her own needs. A client might, do well having their own place, but once they get that first of the month check, their money's gone. So they might say, well, if you took a class on money management, that might really be helpful for you. What do you think about that? And they're like, that would probably help, because I realize when I do get money, I'm not managing it very well. So, so you're helping them kind of see some of those, identify some of those kinds of things. The case manager will serve as a primary advocate for the patient and coordinates all relevant services. Like I said, the case manager work similar, but they're not the same. A case manager encourages a positive and proactive identification of resources in the patient's environment, and this includes community agencies and social supports. And the examples given are friends, families, and neighbors. So whatever positive, resources they have available, they're there. They're there. They just, if they were caught up in their addiction, they probably didn't realize it, or forgot, or but those support people are there. Works with patient in the community to maximize the quality of the provider's perceptions and the patient's experiences. So, it's important to understand what your perceptions are for the client in providing, those resources, but that the client is understanding, or the patient is understanding, that you want them to have the best experience when they go out into the community and develop that support structure. So you understand what their experiences are in doing that, and what's worked for them in the past, what hasn't worked for them in the past, where were they comfortable going if they identified a specific church, or something like that, or a traditional ceremony that they want to get more actively involved in. You want to be able to identify what that patient's experiences were, and working with that, with the linking them up with the right support people. Research is key in any kind of work that you do with in any agency. There's different types of treatment modalities. There's different types of research that you can do as in your agency to help you as a clinician. Some case management research compares research results across case management oriented programs is difficult because of the way the case management concept is defined. So more study is needed regarding the degree to which the type of program influences retention. Okay, so as you're out there looking at different types of our approaches to case management, the strength-based is really one that does work and is very helpful. Here's some research sites that if you want to take a look at, there's a lot of really good information in there. There's a lot of cutting edge technology. Like I'd mentioned, the virtual counseling programs that are starting now. That's really new. People are more comfortable coming in as an avatar into a counseling group room for group counseling, going into individual counseling in this avatar set up environment. So it's nobody. You could be working with your neighbor. You would never know it because they've set themselves up as an avatar, and but they're getting the work, providing the services, getting the care that they need. But there's information out there on that if your agency's interested in something like that. These are some links, I guess, that I would encourage you to take a look at and see what's available, what's happening out there in the addiction world, health world. Okay, so we've gone through the referral process. We've gone through the service coordination and documentation process, the community case management model of strength perspective, and we've taken a look at the research part of it. Like I said, in summary, referrals are working with those agencies that are going to help better provide adequate care for the client. And it may be a variety of referral sources, but it's going to be done in a fashion that's agreeable to the client, to the agency, to your clinical staff. Everybody's working together for the benefit of that client's care. Coordinating those services, like it indicated, the recovery-oriented service care, that community diagram that we showed you early on. Get to know that diagram, and you'll be able to coordinate some of those adequate services needed for the client, and document, everything. Like I indicated earlier, sometimes I was told that anything I document, think of it as a legal document. So if anything ever got called into court or called to question, you have adequate documentation to support the work that you're doing for that individual. So documentation is very, very important in getting those releases of information, informed consent. If you're working with a youth population, you have to have a lot of, I think, extra documentation involved in the chart, and releases of information. Things work a little bit differently when you're working with youth. The community case management model, again, strength-based, building off of what the client already has within themselves, identifying that and encouraging them and pushing them forward and helping them, empower them to stand on their own and identify those resources and those individuals that will support their recovery process, and doing more research. There's always new things coming out in the field. There's a lot of money out there, grant money, that'll help in the area of research. If I don't know where your agency's at with doing some of this, but like I said, the documentation that you might be using is to collect data, additional data, because somebody's involved in a research project to try to see how they can better improve treatment modalities or treatment approaches, or documentation or forms, or how we take notes, or how we what types of forms are we using. I mean, there's all kinds of things that we can provide better services for, and help not only us as clinicians, but our overall agency. So keeping those things in mind, that's kind of the presentation as a whole. So we're going to open it up, I think, now to questions or any comments that you might have for me.
Great, thank you so much, Dee. Looks like we already have one question, but before we go to that, I'll just remind people that questions can be typed into the Q&A pod, which is just to the right of the presentation. So we'd welcome your questions at this time. So Leo is asking, do you use the ASI?
I've used the ASI before, and it can be, yeah, if that's what that agency's using, absolutely.
And maybe for those who might not be familiar, is that a particular form of documentation?
That's a severity index, addiction severity index that's used, ASI, and it's different areas of uh, care, not care, but different areas to look at in where a client is at in their when they're coming in. So they're looking at their housing, they're looking at their legal aspects, they're looking at their social aspects, they're looking at their, so there's different areas that they're working with and identifying to help address whatever issues the client is coming in with.
Great, thank you. Let's see. All right, we don't have any other questions at this moment, but please continue to submit those. I'll just go through reminders here while we're waiting to see if any questions come in. Right now we have upcoming webinars that we're offering on the screen, and we also added, there's a pod at the bottom of the screen, at the very bottom right, where we have links to many of our upcoming webinars. So you can click on each one, and then the little browse to button will actually direct you to the registration for those webinars. So if you're interested in those, please do so. And then I just wanted to remind everyone too that we will be sending out an email follow-up that should come tomorrow. It will include a link to the recording of this webinar, handouts of the presentation, a CEH request form, and it will actually also include a link to the survey in case you don't get redirected, because we would love to have your feedback. So please make note of that. We do have a question from Corey. Can a multidisciplinary approach be used in case management?
Can a multidisciplinary approach, give me an example, Corey?
All right, she says, or I'm sorry, Corey, I'm not sure if Corey is he or she, but Corey said the client is also involved with child protection and probation.
Yes, you're going to want to work with both entities as well with case management, but being mindful of the confidentiality issue that I mentioned before, so that you're understanding what type of information that you're sharing between or with the two. But yes, you can use a multidisciplinary approach. Does that help? Good question.
Yes, thank you.
Good question.
Great, thank you for those questions. I think we will go ahead and close out at this time then, and if you have additional questions, please feel free to email me, and we can always forward those on to Dee, and she can address additional questions later if possible. And so thank you all for joining us. Thank you, Dee. Do you have anything else you wanted to leave us with, or any last?
I want to thank everybody for being online. I appreciate all the work that you're doing out there. You guys are at the front lines. Keep doing what you're doing. Remember, progress, not perfection. Thank you.
Great. Thank you so much, Dee, and thank you, everyone, and hope you have a great rest of your day.